So this morning there was a symposium about the use of neurofilament in the biology of SMA and in the emerging potential of its use as a biomarker for measuring the disorder itself. What's fascinating about neurofilaments is that they are a protein that is expressed in motor neurons everywhere, but especially in motor neurons. And in the setting of a disorder in which there is degeneration, those neurofilaments are released into the environment, whether it's the CSF or the blood. So it's a measure of degeneration. And in the amazing case of an SMN enhancing drug like nusinersen, but probably also the case with the other SMN enhancing agents, the either gene transfer or the small molecule approaches, the once very high levels drop. So a high is bad, dropping it in the context of therapy is good, but if it drops on its own over time, that's a measure of its decline as a function of ongoing loss. And so neurofilament levels naturally descend to a normal level or slightly above normal in people who've lost all the motor neurons, and hence there's nothing left to leak. So the fascinating thing about the neurofilaments is they appear to be a very short-term, very rapid measure of the process of degeneration rather than the outcome of degeneration. We have qualified the drugs for SMA based upon the fact that if you give the drug now, a person is better off in the future or less bad off than they would be otherwise. There's now the potential that we could use these neurofilaments to measure immediately, have I engaged the target, have I stopped degeneration, and not have to wait for whether or not kids and adults are worse off as a consequence. So the question is how will these measures of neurofilament being spilled into the blood or the CSF, how will that change management? It's a good question, and I think there are a couple of ways in which it will be very important. The easiest and simplest thing that I think we'll see in the matter of a year or two is to answer the question of when should we start therapy. We know that with the newborn screening program, babies are going to be identified as having SMA within the few days or weeks after they're born. Fantastic. But suppose we know because of the genotype that child's not supposed to manifest symptoms for months or years or maybe a decade. When would be the right time to start therapy, knowing that every therapy has costs and potential complications and difficulties with it? Should we start therapy before or after, or what would be the criteria? Neurofilament increases offer the opportunity to see the beginning of degeneration before we can see it on the surface, before damage is being done. So that's one easy thing that I can imagine happening. Another thing we can use is, at least for some of these other therapies, we can use as a short-term assay of whether the therapy is, we call it target engagement. By giving the therapy, does it look like we're making a difference before degeneration happens, because after it does, you can't reverse it. Can we prove that we've biochemically addressed the problem, resolved the problem with the neurofilament features? And then the third thing that I think is going to be useful, and this is more research world, is I think we'll be able to use this to adjust therapies. Do we need to give more or more frequently or less? Or how can we adjust therapies so that it's least burdensome? And then the final issue is there a purpose to combining therapies? Not only is there something to be had from changing more frequently or less frequently, but will two be more than one? It's very possible that two is not better than one. And I'd like to not burden somebody with the requirements to get two therapies if one is enough, or in reverse, if two is better than one, we absolutely want to go there. So some of the insights about neurofilament were presented in a platform presentation today, and we've also had posters that describe this in detail for folks who want to get into the internal workings of it. There have been other posters that suggest not just NFH, but also NFL might be useful. And to be honest, it doesn't matter. We will find which one has the best signal-to-noise ratio and helps with the functions that this can do best, and data will out. We hope and expect that neurofilaments will allow us to do to refine the protocols that are used to treat quickly. We hope and expect that it will help us to define which patients need therapy when, and start therapy before they start manifesting weakness to prevent or minimize it. To see about the potential for combination therapies, or to change the dosing regimen, more or less, or more frequent or less frequent, to make the therapies itself less onerous. There's a lot of things this insight can do. This is going to be, I think, and we need to qualify it, a biomarker of the actuality of degeneration, rather than the product of degeneration. When motor neurons degenerate, eventually there's weakness and complications of that. This is actually a measure of the process of weakness and potentially being able to rescue people back before that goes too far.